Hi doctors, how are you? Welcome to week 2. And this week we are still stuck with pharmacology, and sadly the next week also is pharmacology because it's an annoying topic, it's a basic topic, it will cover a lot of stuff, it will save you a lot of concept that you need for medical management. And as usual, we don't care about the question, we care about the concept and the follow-up question. I see you really enjoyed the first one. Hopefully you will get some good information out of those 5 questions and you can add it to your knowledge to save you more time and to make you more confident about your information for the AFK exam. This is Mohammed Musa from AFK Study Plan. Let's do it. First question. A patient with history of infective endocarditis received amoxicillin prophylaxis 5 days ago for a dental scaling procedure. He now present for extraction of an infected molar, which is the most appropriate prophylactic antibiotic. 2 gram amox, 600 milligram Clenda, 500 milligram azithromycin, or no prophylaxis is required. For prophylactic antibiotic, this is a very annoying topic. We have a lot of guideline, even the difference in guideline between Europe, Canada, USA. Anyway, the most current one is to think about 2 things. First is the condition, medical condition of the patient himself. Second is the procedure you're going to do. So the procedure here is extraction. So antibiotic is warranted for sure, as the patient history is infective endocarditis. We have other condition, we have debate about this knee replacement, joint replacement. Let's save it for different question. But anyway, the patient has this infective endocarditis condition and he will do extraction. So he need it. But the question telling you he did take amox 5 days ago. So what you are going to do? To give him amox again or to move to second category, which is Clenda or azithro. So simply put, the updated guideline 2021 American Heart Association scientific statement on the prevention of Viridans group. So this is the name of bacteria responsible for infective endocarditis, streptococcal infective endocarditis, which is now reflected in the modern dental and medical references. What is the update? Clindamycin is no longer recommended for infective endocarditis prophylaxis. Why? Higher risk of adverse reaction, which is C. difficile infection. C. difficile infection is infection happen in GIT, mostly in the small intestine, leading to what we call colitis. The patient will have severe pain in his stomach, diarrhea. It's a nightmare when it happens for your patient. And the management for this one is slightly tricky. So if you know about it, maybe I can read some comments about it, and we're going to cover this later when we go to medical management. So patient, for this, he does require antibiotic. But the second part, the patient did take amox. The patient did take amox. If amoxicillin was used within the previous 10 days, so this is the cutoff. If he did use it in the last 10 days, no, we are going to go to the next antibiotic. Why? Because increasing the dose will make the patient go toward amazing bacteria resistance. We don't allow our patient to develop bacteria resistance. So we're going to go to different class, which is not Clenda anymore. It will be azithro or carithro or doxycycline. And this is the table for the medication. So we start with amox. The dose is extremely important. Please memorize the dose. When you see question about the dose, it's a giveaway. Don't lose this giveaway question. Ask about dose for kids, for adult, the time frame when you are going to give it. If you forgot to give it patient, like you realized later what you are going to do, just call him immediately, ask him take medication. And the second is azithro, carithro, and after that we can go with doxycycline. So here, clindamycin is not removed from this guideline. Azithro is the correct one, and no prophylactic, no, he still needed. Infective endocarditis history and extraction. So if the question here, infective endocarditis, take amox, he come here today for RCT, non-surgical RCT, yes, no prophylaxis. So just read carefully a scenario so you can pick your answer. Next question. Which of the following patient has the highest absolute contraindication to receiving ketorolac? So what is ketorolac? It's a potent NSAIDs. Potent, why? Because it has most selective one to be related to COX-1. And why we do not love this one? Because COX-1 is responsible for the beneficial prostaglandin, prostaglandin E2, prostaglandin I, which is responsible for protection of the stomach and blood supply to the kidney. So he's asking about the highest absolute contraindication for this most potent NSAIDs coming to COX-1. Patient with controlled hypertension, patient on long-term corticosteroid therapy, patient with active peptic ulcer, patient with mild renal impairment. So controlled hypertension, we said we minimize, make it 5 days, we avoid ketorolac. We love to go to naproxen. Why naproxen? Don't ask me. They make a study, they found naproxen to be given in a good way for patients with hypertension. This is what they found. Patient on long-term corticosteroid therapy, not the best way. So now we are between these two, active peptic ulcer or renal impairment. But look here, active peptic, mild renal. So both are contraindicated, but if you are going to pick one, which one you are going to pick? Amazing, active peptic ulcer. So this is a problem. You are going to block COX-1, COX-2. Ketorolac most likely will block this one more than that one. So you are going to exclude this prostaglandin E2, protect stomach and kidney function here. Just to explain, it's responsible for the blood supply going to the kidney. Ketorolac, potent NSAIDs with a strong analgesics as anti-inflammatory effect, is commonly used for short-term management of moderate to severe acute pain, often an alternative to opioids. However, ketorolac has a high risk of GI toxicity because it strongly inhibits COX-1, leading to less prostaglandin E2, less gastric mucus and bicarbonate secretion, and less mucosal blood flow. So out of these options, yes, active peptic ulcer will be absolute contraindication. Minimal, mild renal impairment, reduced prostaglandin, yes, here use with caution. And controlled hypertension, again, relative contraindication. So the answer here is this one. Just a hint. When you read question and you see two options and you feel, oh, these two options are for sure correct, read again for the keyword in the question, or read again in the option. Maybe one word will tip you off out of one option, because this is the most common feedback. I read question and I have two answers. I'm sure both answers are correct. Just read the question again. Read for the keyword in the question itself or a word in the option that tip you off from this option. Third question. A patient taking dabigatran present with uncontrolled post-extraction bleeding. Which agent is the most appropriate specific reversal agent? So we are a dentist, we are doing extraction. It's our job to control bleeding. This is the rule of thumb. Think about it this way. Medical doctor will hate you when you ask them to stop the medication, because to stop the medication, develop MI or develop CVA, so he's under the hook. So they don't like it. They will not stop it. He will ask you, follow your guideline. So the guideline is so simple. If I have patient doing extraction and he's taking medication to avoid recurrent MI, to avoid CVA, to avoid embolism in his lung, so this is really dangerous condition. So it's your job as a dentist to manipulate that extraction, a traumatic extraction, figure of 8 suture, giving him some topical measurement like sponge foam inside the socket, whatever. It's your job to deal with it. But now the patient come with uncontrolled post-extraction bleeding. So uncontrolled is not like usual. So here we need to go with reversal agent. So what do you think? Vitamin K, protamine sulfate, hydrozymab, or fresh fluorescein plasma? So for this, easy peasy, the vitamin K is one for warfarin. Protamine sulfate is one for heparin. Hydrozymab, or this one like very weird one, is for dabigatran. This is specific and rapid reversal agent. Fresh frozen plasma, this is for clotting factor. It will be ineffective. Why? Because this dabigatran, the one at the problem leading to this problem, is working by acting over the thrombin, by doing what we call direct thrombin inhibition. So we need to reverse this one by giving him hydrozymab. Unlike giving him fresh frozen plasma will help, but will not act against this one. How does that work? Dabigatran direct oral anticoagulant function as a direct thrombin inhibitor. Unlike warfarin, dabigatran does not interfere with vitamin K clotting factor, so giving him vitamin K will give him limited benefit. According to Katzang Pharmacology and current AHA and ACC anticoagulant guideline, hydrozymab is a humanized monoclonal antibody fragment specifically developed to reverse dabigatran. It binds dabigatran with very high affinity, neutralizing both the free and the thrombin-bound dabigatran. So this is very important for you to know the antidote for each one. This is for heparin, this is for warfarin, and this is for the dabigatran. In our course, we develop what we call legacy reference. So what is this legacy reference? Legacy reference, we take the most important slides because not all slides created equally. This slide, as you can see, giving me the intrinsic pathway, extrinsic pathway, and how you deal with this one, what is the clotting factor here, the medication working, even the antidote is written here. So this is really a nice one. What else we can add from tonight's session? This one also need to be added. So sometimes ask about the dose, duration, like the what time, the dose for adults. So these are giveaway question. Don't lose those easy questions. Okay, next question. Which vitamin K dependent clotting factor is most rapidly depleted after initiation of warfarin therapy? Factor 2, factor 7, factor 9, factor 10. I remember like this happened with like different concept, and then I know it's the cranial nerve number 5, and I was reading the question, I cannot see number 5. I was like, man, what is this? So you need to know this. This is 2, this is 7, this is 9, this is 10. So all are related to warfarin because he's telling you here in a fancy way, vitamin K dependent clotting factor. So these are the factors that warfarin is working against. So simply put, let's think about the half-life. So half-life of factor 7, as you can see here, is almost 6 hours compared to others, which is high. So you can say with confidence that the first one to decline is this one. So again, the warfarin will come. We'll see these 4 factors. He will work over 4. But which one of those has less half-life? Because he will work over this one, some will still active. So this active will circulate inside blood. So according to the half-life, this one will decline first. It's not like he working here over than those. No, it's working over all, but this one has shorter half-life. So warfarin exert its anticoagulant effect inhibiting vitamin K epoxidase reductase, which is required for the alpha carboxylation activation of vitamin K dependent clotting factor, which are those factors. The rate at which each factor decline after starting warfarin depends on its plasma half-life. So the answer here will be factor 7. Okay. Last question for today. Which antibiotic is effective against anaerobic bacteria? So we are looking for not to be working against anaerobic bacteria. Metronidazole, clindamycin, gentamicin, amox, and clavulanic acid. So the name of bacteria, sadly we need to memorize it, but not at this point. Going forward in the weekly quiz we do together, we're going to add more bacteria, but now let's be sure with the name of pharma first, the medication first, mode of action, and then let's move forward with bacteria later. So gentamicin is aminoglycoside antibiotic which is ineffective against anaerobic bacteria. Why? Because its mechanism of cellular uptake. So how does it work? Aminoglycoside require oxygen-dependent active transport to enter bacterial cell. Oxygen-dependent. So the question asks about anaerobic. Anaerobic, which here to make it not. So this is against. So this kind of bacteria is working when there is no oxygen. Is working without oxygen. Even there is some bacteria, we call it obligate anaerobe. If it exists in an environment where we have oxygen, boom, it's done. So this antibiotic, gentamicin, is working by this oxygen-dependent active transport to enter into bacterial cell to do its action. Anaerobic organisms lack the oxygen-dependent electron transport system necessary for drug uptake, so it will be ineffective. Gentamicin cannot penetrate anaerobic bacteria, rendering it ineffective. In contrast, antibiotics such as Metro, Clinda, and amoxiclavulanate have excellent anaerobic coverage and are commonly used in odontogenic and intra-abdominal infection. And these are the table for us. Metronidazole excellent against anaerobic, Clinda is good, gentamicin none, amoxiclavulanate, this is broad spectrum, covering anaerobic oral flora. So the answer for this question is gentamicin. So out of these 5 questions, I would like you to recap about the most important information. The most important information is related to the prophylactic antibiotic. What is the history that you need to know for sure, and what is the surgery or the procedure done for the patient, and then what is the antibiotic to be given. This is number 1. Second, I would like you to understand about the contraindication for NSAIDs. how does it work, COX-1, COX-2, what is to be given, what is not to be given, and the interaction between the medication and the other one. And then we moved for the anticoagulant, antiplatelet. We discussed about warfarin, we discussed about the antidote for the 3-protamine sulfate for heparin, warfarin, vitamin K, hydrozizumab for the dabigatran 1. And we discussed about warfarin, 10-972, 72 decline first, and finally about the bacterial action and antibiotic. Hopefully that can give you like 5 ideas that you can dig more about it with your course, with your material, with whatever way you would like to study. And next week will be our last week for pharma, and then we're going to move to local anesthesia. See you next Sunday.